Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your free on-the-go source for radiology board review. On this episode, I will continue our learning of radiology by presenting in a question and answer format questions that all pertain to calcification. I like discussing all things calcifications for radiology board review because this will force us to jump around between many organ systems and many different age groups, and that is a good representation of what will actually happen on the day that many of you take your ABR core examination. You will continually for 2 days be bouncing between details of various organ systems and various age groups, and it is important to be able to mentally switch between, for example, breast imaging, abdominal imaging, neuroradiology, interventional radiology, cardiac imaging, and so forth, with a lot of physics scattered in between. On this episode, I will focus on high-yield concepts pertaining to calcifications with different organ systems and different disease processes. Without further ado, let's get into the first question. What is the mechanism whereby Crohn's disease makes calcium stones in the kidney? Again, by what mechanism do stones in the kidney form in patients with Crohn's disease? And a more detailed question is, can you be specific about what type of calcium stones are most associated with Crohn's disease? Crohn's disease is associated with calcium oxalate stones. Oxalate normally binds with calcium in the bowel lumen and is secreted in the stool. With fat malabsorption, such as with Crohn's disease, the calcium in the bowel starts binding to the fat more than it binds to oxalate, and what happens is the oxalate is then able to be reabsorbed at higher than normal levels, and the oxalate is then renally excreted. This renally excreted oxalate can then bind with calcium and form calcium oxalate stones. So to recap, Crohn's disease malabsorption increases the amount of fat in the colon. This binds calcium, which allows oxalate to be absorbed and renally excreted. And in the kidneys, this oxalate can form calcium oxalate stones, and that is the mechanism whereby you can get calcium oxalate stones in the setting of Crohn's disease. Next question. How does bile contribute to this phenomenon of calcium oxalate stone formation in Crohn's disease? The answer is that bile helps with fat absorption, and bile is normally excreted into the small bowel to promote fat absorption, and the bile is then reabsorbed in the ileum as part of the enterohepatic circulation of bile salts. Okay, bile enters into the small intestine, helps absorb the fat, and once the bile gets to the ileum, it is reabsorbed and shunted back through the liver into the gallbladder. In patients with Crohn's disease that have ileal dysfunction, and also in patients who have had ileal bowel resection, the bile is no longer able to be reabsorbed like normal. And as we already said, that fat malabsorption then allows calcium to preferentially bind fat instead of oxalate. The oxalate is then absorbed and renally excreted, and you end up with calcium oxalate stones. I hope that is clear at this point. Let's move on to a bonus question, and I will have several bonus questions that are related to topics we are discussing, but not necessarily related to calcium. However, I want to make sure and cover these at some point, so I'm throwing a few bonus questions into this episode. So your first bonus question, Struvite, that is Struvite, struvite stones classically form secondary to which bacteria? Can you think of some bacteria that are common in the setting of struvite stone formation? Struvite stones are classic on board exams, and you need to know that they have ammonium that results from urease in the setting of Proteus and or Klebsiella. So the bacteria associated with struvite stones, Proteus and Klebsiella. Next, what are top differential considerations for a spiculated mesenteric mass that is calcified? When you are presented with questions showing you a spiculated and calcified mesenteric mass, you should think of things like desmoid tumor, carcinoid tumor, and sclerosing mesenteritis. Sclerosing mesenteritis has several names, which include retractile mesenteritis. Carcinoid is most common about the terminal ileum and can also be seen about the pancreas and is arterially enhancing. Retractile mesenteritis has a classic misty attenuation. And note that all three of these have various imaging manifestations, but one way that they each can present is with a spiculated, calcified mesenteric mass. Next, what is milk of calcium, and how does milk of calcium typically appear on imaging? I have covered this in a previous episode on calcifications pertaining specifically to breast imaging. So if you want further review of breast imaging calcifications, refer back to that episode. To answer this question, milk of calcium on imaging typically appears as layering sediments of calcium within cysts. So on imaging, the appearance can show T-cupping or a meniscus-like effect with calcium sediments layering dependently within cysts. On X-ray imaging, you will not be able to see the cysts most commonly, but you can still see the T-cupping or meniscus-like appearance of the calcium, which lets you know that this is milk of calcium. Next question. Milk of calcium is most classic on mammography. What is the classic appearance of milk of calcium on a craniocaudal view, and what is the classic appearance of milk of calcium on a true lateral view? On a craniocaudal view, milk of calcium typically looks like round, amorphous, smudgy calcifications. On ML or LM or on an MLO view, you will see T-cupping and layering, especially on extended hold views. And an extended hold view is a view in which the patient is held in compression for an extended amount of time, perhaps for 1 or 2 minutes, and then you image. And the reason you might do this is because you allow the breast more time in compression to have the calcium layer out in those cysts so that you can see the layering milk of calcium. The key for milk of calcium on mammography is that the calcifications change configuration between orthogonal views. So you would expect them to look amorphous or smudgy on a craniocaudal view and demonstrate T-cupping or layering on a true lateral or MLO view. Other types of calcifications in the breast do not classically change configuration on orthogonal views, so that is a key for milk of calcium. And remember, if you confirm milk of calcium on imaging, that is a BIRADS 2 benign lesion. Next, what if grouped calcifications on a mammogram appear amorphous on orthogonal CC and MLO or true lateral views? Okay, what if it looks amorphous on both views? What then? If calcifications are amorphous on both orthogonal views, you have not confirmed milk of calcium, and you need to biopsy these if they are new. Entities like DCIS can present with new or increasing amorphous calcifications. So the key here is that amorphous calcifications alone are not enough to confirm milk of calcium. You need to see that amorphous appearance on a craniocaudal view with the change in configuration with the layering and teacupping on the MLO or true lateral views. Next, a pathologist is examining core biopsy specimens from a stereotactic biopsy of calcifications thought to possibly be related to milk of calcium. The pathologist does not see any calcifications in the biopsy specimen under standard microscopy. What could the pathologist consider adding in order to potentially reveal calcifications that are present but not seen on standard microscopy? The answer is that the pathologist could evaluate the biopsy specimens with polarized light, which may show calcium oxalate, which can be seen with benign milk of calcium. Calcium oxalate is seen under polarized light microscopy, whereas calcium phosphate is the more common type of calcification seen on mammography and on standard microscopy. That calcium phosphate is what stains purple with H and E staining. Calcium oxalate, on the other hand, requires polarized microscopy to make it manifest in many cases, and calcium oxalate is also more likely to be benign and associated with milk of calcium. So especially if you have biopsied something on a board exam question that looks suspicious for possible milk of calcium, and the question says that the pathologist is not seeing calcifications, and if an answer option is use polarized light, that is likely the correct answer. Next, besides the breast, can you think of another organ that can show milk of calcium on X-rays? First, I think you should think of renal cysts in which calcium can precipitate. Renal milk of calcium can also be seen in calcial diverticulae, so not exactly cysts, but the diverticula in the calyces. And milk of calcium in the kidney also can show layering, especially on an erect film, and can also look rounded on a supine film. So you see the same principle in mammography can hold true elsewhere with milk of calcium, where you see a change in configuration between different types of positioning. In this case, you would often see on an upright film that layering, and if the patient is getting a supine abdominal X-ray, that calcium may look more rounded. Now, you can also have milk of calcium in other places like the gallbladder, but I think that is less likely to be tested on a radiology board exam. Next question. This is kind of a question where you either know it or you don't. What are Randall's plaques? Randall's plaques are subendothelial deposits of calcium carbonate or calcium phosphate within the loops of Henle within the kidney. These Randall's plaques appear hyperdense on an abdominal CT, but are not renal stones. And that is really the key point, is that Randall's plaques should not be confused with renal stones. The key for Randall's plaques is that these are abutted by 50% or greater renal parenchyma, meaning they are intimately associated with the renal papillae and renal parenchyma, whereas stones can be seen free-floating or nearly free-floating. Randall's plaques will be intimately associated with the papillae and renal parenchyma and will be abutted by renal parenchyma by greater than 50% of the area. Randall's plaques are often thought to denote an increased risk of stone formation, possibly by acting as a nidus for calcium to precipitate. Nonetheless, they are normal and fairly common, and if you don't know what Randall's plaques look like, go ahead and look it up online or in your favorite textbook. Next, what is a key sequence that is necessary on a triple phase CT to differentiate contrast from calcium on CT angiography, such as for endoleak evaluation, okay? So you are doing an endoleak CT angiography triple phase examination. What sequence is key to differentiate between calcium or contrast, which are both hyperdense? The answer is that pre-contrast imaging is key on a triple phase CT to differentiate between calcium and contrast. If the hyperdensity seen on later phase images is also present on pre-contrast images, then it is calcium. If the hyperdensity that is seen on later phase images is not present on the pre-contrast image, then you should presume that that represents contrast, such as in an endoleak. Next question. What are differential considerations for renal medullary nephrocalcinosis? Now, I may have covered this on a previous episode. To be honest, I can't remember entirely. Nonetheless, repetition is a key for learning. What are differential considerations for renal medullary nephrocalcinosis? For this, I like the mnemonic HAMHOP. That's HAMHOP. H is for hyperparathyroidism. A is for acidosis, as in renal tubular acidosis. M is for medullary sponge kidney. H is for hypercalcemia and or hypercalciuria. And you can see hypercalcemia and hypercalciuria commonly with entities like sarcoid, milk alkali syndrome. O is for oxalosis, as in Crohn's disease or ileal surgical resection, as we already talked about, okay? O, oxalosis, calcium oxalate stones also contribute to renal medullary nephrocalcinosis, okay? O, oxalosis, and the HAMHOP mnemonic. And that final P is for papillary necrosis. So differential considerations for renal medullary nephrocalcinosis are HAMHOP, hyperparathyroidism, acidosis, as in renal tubular acidosis, medullary sponge kidney, hypercalcemia and hypercalciuria, oxalosis, and papillary necrosis. Remember that I mentioned on the prior episode, I believe, that a unilateral calcified kidney should make you think of tuberculosis rather than nephrocalcinosis, because renal medullary nephrocalcinosis would be expected to be bilateral. So if you see a unilateral calcified kidney, you would think tuberculosis rather than nephrocalcinosis. Here is a bonus question. What is a reasonable differential diagnosis for renal papillary necrosis? And for this, conveniently, you can think of the mnemonic NSAID. And this is convenient because the N is for NSAID, because NSAIDs are a leading cause of renal papillary necrosis. So NSAID, NSAID, the N is for NSAID, the S is for sickle cell disease, the A is for acetaminophen, the I is for infection, such as TB or pyelonephritis, and the D is for diabetes or severe dehydration. Those are all causes of renal papillary necrosis. Remember the mnemonic NSAID. The calcifications with renal papillary necrosis may be curvilinear or ring-shaped, and they can look like arcs of calcifications around the papillary tips. The calcifications from renal papillary necrosis can also have a triangular-like appearance, especially with more extensive calcifications of the papillae. If you see detached triangular-like calcifications, this should make you think of sloughed papillae in the setting of renal papillary necrosis. Next question. What are characteristic imaging findings of medullary sponge kidney? Think about that for a moment, and I do consider medullary sponge kidney to be high yield on board exams. So if you don't know much about medullary sponge kidney yet, take some time to read about it and make sure you are set for this entity. pyramid-like calcifications of the renal medulla on a non-contrast CT that then develop a paintbrush-like appearance on delayed post-contrast images should make you think of medullary sponge kidney. This is one entity where I think the images just look really nice, and perhaps that is a reason why this is highly tested. With medullary sponge kidney patients, they are often asymptomatic, but they can present with things like intermittent flake pain or recurrent urinary tract infections, and the cause of that is ureteral obstruction by small calculi in dilated renal tubules. And what we are actually seeing on the non-contrast sequences where you have that pyramid-shaped calcification are these small calculi that are positioned within the slightly dilated renal tubulars within the medullary region of the kidney, thus medullary sponge kidney. I think of it as a sponge for these small calculi. The medullary pyramids would also look echogenic on ultrasound in the setting of medullary sponge kidney. Let's call it there for now. I will continue the discussion of all things calcium on the next episode. Keep up the good work. Remember that you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.